Hi, good evening, everyone. We have a long night ahead of us, so we don't want to start late. We're still waiting for people to join, but as we wait while they're joining, let's start with the formalities. Tonight we have Professor Chris Vorster as the speaker. So let me just introduce Chris, and then I will give you some tips for the night. So Professor Chris Vorster, a chemical pathologist specializing in the diagnosis of metabolic disorders and other rare diseases, was appointed as the director of the Center for Human Metabolomics at the Northwest University in 2010, where he subsequently established the National Metabolomics Platform. Under his leadership, comprehensive services were established that are nationally used for diagnostic and research purposes. In 2023, Prof. Vorster was seconded to the Diplomics Nngwe program as the director, and this is a national initiative to diagnose undiagnosed rare disease patients through locally provided genomics, proteomics, and metabolomics services. In this capacity, he drives the establishment of knowledge, capacity, and infrastructure that will enable future diagnostic and research applications. Thank you, Chris, for availing your time to do this presentation. I know that a lot of effort goes into preparing for these. We normally just see the 1 hour, but I know it takes you days to prepare. So thank you very much for your time with this. Just some administrative arrangements. If you want to post a question, you're welcome to post a question during the talk. You'll see at the bottom of your screen, there's a chat function and there's a Q&A function. You can use either of these. But this is also your opportunity to directly communicate and ask questions to Chris and other metabolic diagnostic experts in the audience. So if you want to be unmuted to speak, please just raise your hand. You'll see there's a little hand icon also on the bottom of your screen. If you raise your hand, we will unmute you and then you can have a direct conversation. Then lastly, we would like to thank Sanofi for sponsoring this event. We really appreciate the support from their side and the continuous involvement in this cause. Thank you, Chris. You may proceed. We're not going to take any questions, during the talk. You're welcome to post it during the talk so that you don't forget, but we're only going to get to the answer after the entire talk is finished. Thank you, Chris, and good luck.
Thanks, Ilse, and I hope it's not going to be too long of a night. It sounded like you were of the impression that I'm going to keep people busy for a long time. I'm not going to do that. Also, just I have a disclosure. I don't think this presentation is going to be as interesting as last week's presentation, although this is very important to us. There will be some changes in the way in which metabolic tests are requested in 2026. And what I would like you to encourage you to do is to start now so that, come 2026, the way in which you would need to work is already well established. Okay, so before I start, let's just first review what clinical presentations would make you think of an inherited metabolic disease. And we've done this many times, but I'm just going to run through them quickly again. So we're looking at acute and severe presentations, fluctuating over time or during the course of the day, presentations that's triggered by food, catabolic states, energy demands, medicines, a progressive disease or deteriorating disease, a disease that's evolving with new clinical features occurring over time, then some unusual findings or combinations of findings, idiopathic or syndromic diagnosis, and then odors. In terms of the organ systems that's involved, often they're multisystemic, but if we have to rank them, then I think we'll probably start with neurological and then hepatic, then morphology, dermatological, cardiac and muscle, and then ophthalmological and renal. And then what's also quite useful is the patient history. The perinatal history may be very important. Also, if it was normal, that's actually quite important to us. Family history or pedigree. And then it's also a telltale sign as patients that have visited several pediatricians and that had several hospital admissions without a diagnosis. Now, many years ago, not that many years ago, but some time ago, genetic testing wasn't all that available in the country, and I think most rare disease patients were, samples were sent to us. Now genetic testing is becoming more and more available, and it is very important that when you consider testing, that you consider the appropriate test. So, if the presentation is that of a metabolic disease, you should request metabolic tests. We have many examples now of patients that have metabolic disorders with negative genetics. Now, as genetics evolve, that may change, but for the time being, if the patient has a metabolic disease or suspected metabolic disease, you should order a metabolic test. On the other hand, if it is a suspected rare disease that's not metabolic, then of course going a genetic strategy is the right way. And often you would do the one first and then have to do the other one second. So you end up doing both in anyway. But I think it's quite important, particularly in acute scenarios, to request the appropriate metabolic test. And this is what tonight is about. How do I get to appropriate metabolic tests? Okay, so let me first tell you how clinicians currently select tests. And if I click on this link, it's going to take us to our website, but I've already opened it. So I'm just going to put that onto the screen. Now, clinicians don't go to our website. So they're mostly there it's mostly there for us. But why I just want to point you to the website is, sometimes we get asked about testing. And so if you go to the website, you can see here that there's various options. What's applicable for tonight is our diagnostic testing. And if you open that, then you can get information of all the tests that we offer. And this is the test, the cost, the collection protocol, what you can diagnose with it, etc., etc. What most clinicians will do is they will request a metabolic evaluation. And then what the laboratory will request, the laboratory that refer to us, is they will request this full metabolic evaluation that's done on urine. Okay, and if you open this, then this is what it looks like. And it tells you all the different tests that is done if you request this. Now, I'm going to stop here for the moment and just show you how this looks on a PDF. So what's included in this test is some simple tests. Then everything is on urine, organic acids, oligosaccharides, glycosaminoglycans, amino acids, and acylcarnitines. Now, there's several problems with this. One is that first-line test for amino acids and acylcarnitines is not urine. In fact, urine acylcarnitines has got very few applications. And even so for urine amino acids. So first-line test is actually serum amino acids and serum acylcarnitines. And the second thing is that it's not a particularly good basket of tests. So clinically, there are very few scenarios in which you would order these tests. There's a historical reason why this full metabolic evaluation exists. The laboratory started in the 1980s and developed tests and basically just kept on adding those tests to the repertoire. And that's how we ended up with this full metabolic screen. But it's not really appropriate anymore. We need to do better with our test selection. However, the problem is that, clinicians would actually request metabolic testing quite rarely, so it's quite hard then to come up with the correct test if you suddenly encounter a patient in which you suspect to have a metabolic disease. Okay, so what we have been working on is an approach that can assist you in selecting the right metabolic test to order. And that is what I'm going to show you now. But before I do that, I just want to point out, and I know there's some pathologists in the audience as well, is that actually since last year already, we've been working on a metabolic test request form. And the idea with the test request form is that, you have a patient that you put into a certain category and group, and then based on that category and group, you would select the appropriate test to do. But for various reasons, we're not just at a point where we can implement this. And the other thing is that there's likely to be quite a few changes in the beginning, so you don't want the pathologist to go and print these forms and then they don't really get used in the, to such an extent that they can actually deplete them before we need a new version. So we thought that perhaps it would be a good idea if we create an electronic form that, or rather, let's just say electronic selection tool that clinicians can use. And then also give us feedback to tell us, what's working and what's not working. And then hopefully we can get to more appropriate metabolic testing and, give a larger number of patients an accurate diagnosis. So now, again, if you go to our website, nationalmetabolomics.platform.co.za, then you will see at the top here, there is a tab, resources, and then there's IEM test selection tool. And this is where you're going to go. And I'm going to just take you through this form. And it's quite important that you study this before you start to use it. Otherwise, it will actually not give you the results that you're looking for. So if we can just go through this in a stepwise way, I'm also going to show you some examples. So you'd start off by just entering your email address. And the reason for this is once you're done with this form, we're going to mail you this form to your email address. And then this form must be sent to the pathology lab or be handed to the phlebotomist that's going to do the collection so that they know which test to collect. It's also going to provide us with some additional rights that I'll show you as we proceed, but that's basically the reason why you would enter your email. Then step 1 is to select a correct category and group for your patients. So I'm just quickly going to read it here. A code should be selected based on the patient's clinical presentation. There are 2 main categories: an acute or progressive presentation. So we put that in 1, which is a bit different from what it's done traditionally. And then second category is storage diseases, which includes hepatosplenomegaly and also other storage-related signs. Each category is further divided into several groups. When multiple presentations are present, select the most prominent category and group. For example, if a patient presents with massive hepatosplenomegaly and mild dysmorphic features, code B1 should be chosen instead of code A6. So code B1 is primary hepatosplenomegaly and code A6 is dysmorphic features. But what I can tell you is that we've designed these categories in such a way that if a disease can present in more way, then it's included in all the categories where it can present. So if you're worried about, there are more than one presentation and you're not sure which one is the predominant one, you can probably just select any one of those, and that should still lead to an accurate diagnosis. It will, however, have an influence on the number of tests that is selected. So one strategy may be more appropriate than the other. And that's why we want the most, the predominant presentation. Okay, so let's just for the moment say that we're going to select something that is going to be easy to go through. So let's say we select primary hepatosplenomegaly. Okay, then the next step is, based on the code selected in step 1, a list of recommended routine and metabolic tests are provided. Review the suggested test carefully. Any test deemed unnecessary can be deselected. So, you may have already performed some of these tests and you don't want to do it again. So then you can just deselect them, and additional tests can be added as needed. So if you're worried about something, you can always just add it. Pay close attention to the footnote. This should actually be legend. The footnotes of the legend and the sample requirements provided. These sample requirements are also printed with the test request to ensure that they are readily available for the phlebotomist's review. Okay, so if I can just take you through this. So there's a number of just pathology tests, and then there are some metabolic tests. And you can see that based on the category that I've selected, it is already pre-selected the correct test that needs to be done. Now, if I've selected something else, then, it's going to give me another selection of tests. Now, it is very important to study these footnotes, not so much the collection footnotes. You'll see that all the footnotes that starts with collection has got letters in front of them, and it basically just give guidance to the phlebotomist on the tubes that needs to be collected. However, these numbers are very important. So, for example, you would see here that quite a large number of tests has got the number 1 next to it. And if you go to the legend, you'll see that you only request this if hypoglycemia is the primary presentation. Or if hypoglycemia is present. That should probably be a better way of describing it. So let's say, for example, we did select ASD or behavior abnormalities, and you review the test here and you get to blood ketones. Then you should go to the legend and you should see that you should only select this if hypoglycemia is present. Now, at this stage, you may not know if the patient has got hypoglycemia or not. So perhaps as a first round, You may want to deselect these tests because they would only be relevant if hypoglycemia is present, so in order just to decrease the number of tests, you'd want to deselect them. So this is quite an important step with hypoglycemia because there are many, many tests that should be selected if hypoglycemia is present. And so you can run down the list: fasting lactate, ammonia, homocysteine. The list up to here is really the core of pathology tests required in metabolic diseases. TSH is also included here, although it's not really a metabolic disease. It's something that can sometimes catch you out. So we decided to include it there and select it where it's appropriate. Then again here, for example, lactate pyruvate ratio is number 2, and you'll see request if hyperlactatemia is present. So the lactate pyruvate ratio has got no use if the lactate's normal. So you would not select it under those circumstances. So maybe in this case, we want to deselect it again. And then the same goes for vitamin B12 and folate. You'll see request only if macrocytic anemia is present, and maybe you've already done a full blood count on the patient, in which case I should deselect that, and I should then deselect vitamin B12 and folate. And so we can continue. But these numbers are very, very important. It's going to give you a lot of guidance in terms of, if the test really should be selected or not. Okay, so if we can just perhaps run through them. So we've covered hypoglycemia, hyperlactatemia, macrocytic anemia. You'll see number 4 relates to specific scenarios when urine amino acids should be requested. You'll see that most of the time you will request serum amino acid, but there are certain specific scenarios when urine amino acid should be requested, and this is when there's hyperammonemia, renal tubular acidosis, or pellagra-like skin lesions, or urolithiasis. That's the only situations in which you would select urine amino acid. The same goes for urinary acylcarnitines. There are very, very specific instances in which we would advise that. So this would normally be a second round test. The laboratory would tell you, look, we think you should do urinary acylcarnitines. As a first round selection, there's almost no instance in which you would select urinary acylcarnitines. And so on with the list, so you can just review that and make sure that you select the appropriate test. Then we get to the clinical information. So to assist in interpreting the metabolic result and support appropriate recommendations, please provide the following clinical details. Kindly number your responses and ensure that all 6 questions are completed thoroughly as possible. And so this you can just type in here. I do realize that this takes some of your time, but if you provide us with just very key clinical information, it will assist us in helping you to establish the diagnosis. Okay, so this should be entered here. And so the things that we're looking for is the clinical features at presentation. Sometimes, particularly in an ICU setting, the patients become very complex and there are multiple things that one could include. But what we're really looking for here is that key features that the patient presented with initially. So, for example, if the patient presented with neurological deterioration and then later on developed convulsions. Convulsions is probably not such an important feature to present or to report, but if the primary presentation was convulsions, then you would want to report on that. And then, previous medical history of note, radiology results if available, current treatment and feeding regime only if applicable, and then the antenatal and peripartum history only if applicable, and then relevant family history. Okay, now, and I'm going to show you this also in the rest of the presentation. There are some metabolic diseases where it's absolutely critical to have this initial pathology results. And this has been a constant struggle within the laboratory. We see some things or we spot something from the clinical information that you've provided us with, but we don't have the pathology results. And because of things like the POPIA Act, it's now becoming more and more difficult to actually access these results. And so what we would like to do is to get access to these results right from the beginning. So you'll see here as a step 4, we ask that you consider to log me as a copy doctor on the report of the patient. And then depending on which lab you use, you can just select my mnemonic. And if there's other labs that needs to be added to the list, then we would be happy to do so. So you select, just as to say, for now it's Lancet. Next time we'll use Ampath or Pathcare, and then just click that you provide consent. And then you just need to sign here. Okay, and at this point, I think in most instances, we've tried to imagine what the workflow would look like. If it doesn't work, just tell us and we'll change it. But at this point, you'd probably want to submit and then print this form. And if you print it, I'll show you what the printout is going to look like. Then you're going to have a list of these tests that needs to be requested. The clinical information is going to be on there. It's going to show that you have given permission to log me as a copy doctor, and the mnemonic will be on the form. So if you hand this to the phlebotomist, they should have all the information to do this. But then once this form is printed, now it can also be done before you print it, but I think in most cases it'll probably happen after it's printed. There's a section here that the patient should complete, or the parents or guardians of the patient. And this is very, very important. So you'll see here there's a section on consent to additional testing, which says, I consent to the Northwest University requesting additional testing, including international referral, information and reports required for diagnostic purposes, provided that such actions will not be undertaken automatically if there are cost implications without prior consultation. So essentially what we are asking for is, one, we want to be able to request additional information, be that laboratory results or radiology results. And then two, we want to have consent to request additional testing. Now, this is very important in, for example, the lysosomal storage diseases program. We want to discontinue the collection kit, but the collection kit actually enables this. The patient consent to us doing additional testing if we think that it's necessary, including international referral for genetic testing. So if the patient click this, then we can go on and do additional testing. And there are many instances where we can actually do additional testing and where it's not going to cost the patient additional money. But we can't do it because we don't have consent. So if we have that, then we can continue doing this, and everything that we do, or whenever we do this, it is solely for the purpose of getting to a diagnosis for the patient. And then the second step is the consent to contact. So this is the Northwest University may contact me with regards to participation in research and other opportunities that could result in a diagnosis or improve patient care. And there's been many examples of this. You know, sometimes there are opportunities that come along. You know, we get an opportunity to sequence some patients and so on. And again, if we don't have consent to contact them, then we can't include them in the research. When we do this, we always keep you as a clinician in the loop, and we never report to patients directly. So if we do additional testing, it still goes through the clinician. Sometimes the patients contact me and I just tell them, look, you first have to go to your clinician, get the result there, and then once you have that, then you can contact me again and we can discuss it further. But everything always still goes through the clinician. Okay, and then the patient sign, and then it's ready and we have all the information that we need. Okay, now back to the presentation. And I see that time is flying. I understand now why Ilse said that it's going to be a long night. Okay, so just very quickly, this is what the form then looks like. It's got the test here. It's not so clear here, but if you print it, it's a lot clearer. So it's got the test that needs to be requested. It's got instructions for the phlebotomist. It's consent to add copy doctor has been selected. My mnemonic is there. Poor attempt to a signature, but it's there. And then the patient information is also there. And then here's the clinical information. Sorry, I see it's very poor projection on my screen, but if you print it, it will be a lot better. Okay, so just to make sure that we've covered everything, I've told you why we need your email. I've shown you how to select a particular clinical category and group, how to review the test. I've told you to pay attention to the legend, and particularly numbers 1 to 8. Then also the container types that's required when doing the collection and how they should be handled. I told you about the clinical information, the consent to add me as a copy doctor. I've told you about the patient section, and then the cell phone version of this actually works quite well. So you can also do it on a cell phone or a tablet, and that shouldn't cause any problems. And if there are problems, then, you know, please just get in contact with me and we will try and resolve that as quickly as we can. And we want this to be almost error-free by the end of the year. Okay, so let's just do a quick example. So here's a 10-year-old patient that presents with confusion. History and clinical examination reveals the following: previous admissions for encephalopathy accompanied by seizures, history of recurrent vomiting and fatigue, and subtle behavioral changes and learning difficulties. Okay, so if I then go to the form, so I'm going to start off by just entering my email. Oh, no, sorry. Okay, so that is quite quick. And so based on the presentation of this patient, I would think that it's probably a metabolic encephalopathy. I would now go ahead and review the tests. Some of these things I may have done already. I may not know what the glucose is, in which case I need to deselect all of these number 1 tests. I'm only going to select those if I know that the patient has got hypoglycemia and if the sample that I am collecting has got a low glucose concentration. Otherwise, all of these tests are essentially useless. Okay, so I've deselected a few there. I may actually want to add something if I thought that that was important. Let's just add gold here because, I don't know, there was something on his newborn screen or something like that, just as an illustration that, additional tests can be added. And now I need to provide the clinical information. So I'll say present with fusion, previous series. Unfortunately, this thing's got a spell checker. So you don't look like a fool when you send it. And then vomiting. Okay. And then you could say, perhaps say something like supportive previous. Oh, I've already said that. No family history. Okay, so that's going to be quite helpful for the lab to know that. I'm going to select what I need to do, and I'm going to submit this, print it, and then send it on to the phlebotomist to do the collection. And in the laboratory, this is the metabolic test that we're going to receive, but we're also going to receive the results of these pathology results. Now, let me just show you one more example. So this is an adolescent boy that presents with subtle facial dysmorphology, short stature, hepatosplenomegaly, kyphoscoliosis, genovalgum, dysostosis multiplex, joint stiffness, corneal crowding, hearing loss, intellectual disability, speech delay and behavioral changes, and recurrent upper respiratory tract infections. Now, if you've attended 5% of the presentations that we've done in the last 2 or 3 years, you're probably going to know that this is mucopolysaccharidosis, right? I mean, this is the classic presentation of mucopolysaccharidosis. The child's quite old, so we're thinking that this is an attenuated case of mucopolysaccharidosis, not the classical presentation with that very coarse facial features. But you can see he does have some facial features of mucopolysaccharidosis. He's got a hearing aid and so on. And so for me, this would look, fairly much like a mucopolysaccharidosis. So how would I enter this, or which category am I going to choose? So, I mean, I can go with dysmorphology, I can go with hepatosplenomegaly, I can perhaps go with behavioral changes. So if we take our tool, just to show you, if I go with primary hepatosplenomegaly, it is going to select the 6-plex LSD, and it's also going to select urinary glycosaminoglycans. So I'm going to make the diagnosis. On the other hand, if I wanted to go with dysmorphic features, now remember, when you select this, there's a wide range of dysmorphic features. We don't know that this is coarse facial features and dysostosis multiplex. So you end up with quite a few metabolic tests, but you can, of course, deselect them if you think that they're not appropriate. But importantly, 6-plex LSD is selected, and the urinary glycosaminoglycans is also selected. And then just lastly, if I go with, what was the other thing? Oh, yeah, if I go with behavioral abnormalities and ASD, you're going to see that, again, the urinary glycosaminoglycans is selected, and the 6-plex LSD is also selected. When you run down this list of tests and you deselect, make sure you've got a good reason to deselect it. So maybe, yeah, patient's got coarse facial features and you're pretty sure it's not one of these, so you delete this. And then you get to urinary oligosaccharides. And now you should be careful. If the test is unfamiliar to you and you don't know if it could be appropriate, then it's perhaps rather better to leave it in. So that's what I would do in this case. And in fact, This particular case is a case of alpha-monoacidosis. You can't pick that up with the 6-plex LSD and with urinary glycosaminoglycans. For that, you need urinary oligosaccharides. And the test was selected. And if you just keep the selection on, you are going to make the diagnosis. So the test will also help you to keep your options open and expand your differential diagnosis if needed. Okay, I must really hurry up now. Okay, so very quickly, the routine pathology test that we are asking access to is actually very important. And there are some metabolic diseases that we will not diagnose if we don't have these results. So if we don't have your clinical and we don't have these results, we'll miss the metabolic disease. There aren't markers on our profiles. The markers is the clinical presentation combined with some of the routine pathology tests. And I've divided them here into core tests, reflex tests, and then other tests. The core test is pretty much what you would do for a patient that is fairly severely ill. So it's full blood count, liver function, urea, creatinine, and electrolytes, blood gas, fasting lactate with reflex tests, if abnormal, fasting glucose with reflex tests if abnormal. And glucose is a one that you have to pay particular attention to. If you have hypoglycemia, you absolutely must collect fasting insulin, fasting C-peptide, blood ketones, which is a point of care test done by the path labs, cortisol if you suspect Addison's disease, and also for growth hormone deficiency, growth hormone and insulin like growth factor 1. And then in some situations, we need postprandial glucose and postprandial lactate, uric acid, and fasting triglycerides. I'm going to show you this just now. Then other tests that you should consider here is homocysteine, ammonia, CK, and TSH. TSH not really part of metabolic, but can easily be confused, and just make sure that the patient did at some stage have a screen for congenital hypothyroidism. And then there's some other that's also very important that's offered by the path labs. I'm not going to go into them into detail, but I think at some stage we do need a presentation on some of these because they may be overlooked. Okay, so what can we learn from these path results? So what I'm going to go through is hypoglycemia, hyperlactatemia, hyperammonemia, acid-base disturbances, creatine kinase, and then together megaloblastic anemia, B12 and folate and homocysteine, and then just some others that I'll quickly mention. Okay, so probably the one that is, well, I don't think it's the most difficult, but it requires a lot of reflex testing and so on, is hypoglycemia. And an important step in the workup of hypoglycemia, particularly if the patient has got hyperketotic hypoglycemia, is to consider all the secondary reasons why a patient may have hypoglycemia. So these are things like infection, Addison's disease, hypopituitarism, but then also metabolic diseases that present with hypoglycemia because of glucose utilization. It's not a primary disorder of glucose metabolism. It's a secondary effect. And these are the organic acidemias and, for example, galactosemia that can present with hypoglycemia, and then also transient hypoglycemia. In all of these, the patient is going to present with hyperketotic hypoglycemia. So when we get to this category of hyperketotic hypoglycemia, we want to be very sure that we've excluded all the secondary causes. There's one exception, and that is the neonate of a diabetic mom that it presents with hyperinsulinemic hypoglycemia. So that is the exception. Otherwise, it's pretty much hyperketotic hypoglycemia. So, okay, if we move on to the first category, hyperinsulinemic hypoglycemia, patients got hypoglycemia, you measure the insulin and C-peptide, and it's detectable. If you've got hypoglycemia, insulin and C-peptide should be completely suppressed. If it's detectable, it's abnormal. Because insulin is present, there's no counter hormonal regulation, so ketones should be low. These patients are some of the patients that's the most difficult to manage, so they've got constant fasting to constant hypoglycemia, often requiring very high glucose infusions. They respond to glucagon and sometimes also diazoxide. When we look at these patients' metabolic profiles, they're often completely quiet. And that's because the patients has high insulin levels and they're anabolic. So we don't really see anything. In metabolic diseases, we often see things because the patient's catabolic. Here, the patients are anabolic and we don't see much. What you should do in these patients is ammonia and serum acylcarnitines. And there are two, well, according to the old classification of metabolic disease, because many of these diseases have actually now become metabolic diseases. But in the old days, when we considered diseases with metabolic markers to be metabolic diseases, there were two diseases, and that's glutamine dehydrogenase superactivity or hyperinsulinemic hyperammonemia, and SCHAD, short-chain 3-hydroxyacetyl-CoA dehydrogenase deficiency. Now, I've got a nice story of why these two conditions present with hyperinsulinemic hypoglycemia, but you're going to have to ask me at a later stage about that because I'm running out of time, so I'm going to move on. Then if the patient's got hypoketotic hypoglycemia, these patients have got low ketones, but they've got a completely suppressed insulin and C-peptide. So insulin and C-peptide is appropriate, but ketones should have been high, and it's not high, so that's inappropriate. Usually they've got fasting hypoglycemia, not constant hypoglycemia, and the thing that you need to do here is the fasting lactate. And that's going to distinguish primarily glycogen storage disease type 1 or von Gierke from the fatty acid oxidation disorders. GSD1, unlike the other GSDs, have actually got low ketones, and that's just because glucose 6-phosphatase induces lipid synthesis, and for that reason, ketones is often very low. So these patients, they don't have constant hypoglycemia, but they develop hypoglycemia very, very quickly. And then if you measure the lactate, it's typically quite high. Fructose 1,6 bisphosphatase deficiency can also present like that sometimes, but other times they do have ketones. So that's why that's in gray. So if the lactate's only mildly increased to normal, then most likely you're dealing with a fatty acid oxidation disorder or a ketogenesis disorder. And this is where the metabolic laboratory is very useful. You know, if we have organic acids and serum acetylcarnitines, we're going to make the diagnosis. But we're not going to make the diagnosis of glycogen storage disease type 1. So if you haven't given us the clinical and you haven't ordered the correct pathology tests, we're going to miss that and the patient's not going to get a diagnosis. Hyperketotic hypoglycemia, like I said, yes, very important that you've excluded the secondary causes. And then we're going to look at the fasting lactate. If that's high, like in the previous slide, it could be fructose 1,6 bisphosphatase deficiency, although they can also have low ketones, so that could be low or high. But if the fasting lactate is low, then we're in that situation where we're going to look at the fasting glucose and lactate and compare with the postprandial glucose and lactates. And so now you've got a couple of combinations here that can happen. So if you've got a high postprandial lactate and a high postprandial glucose, then what it means is that the glucose cannot be converted to glycogen. So because glucose can't be converted to glycogen, it runs down glycolysis and ends up as lactate. And this is why these patients have got high glucose and high lactate. On the other hand, if you've got hereditary fructose intolerance, then it's the fructose that cannot be metabolized. So you end up having a normal postprandial glucose, but a high postprandial lactate because of the fructose running down glycolysis and being converted into lactate. Then if you've got a low postprandial lactate, but a high postprandial glucose, then it means that glucose is not entering the hepatocytes, and then that's Fanconi-Bickel syndrome. These patients also typically have glucosuria, even though their serum glucose may be quite low. That's quite an important key there. And then if you've got a situation of a low postprandial lactate, but with a normal postprandial glucose, then it means that you cannot convert glucose into glycogen. So these are the glycogen storage diseases where, unlike with GSD0, where you can't make glycogen, here you can't actually utilize the glycogen, and that's why they present in the way in which they do. Okay, then very quickly, lactate. Again, very important. First, exclude the secondary causes: circulatory collapse, hypoxia, failure of cellular respiration, infections, particularly urinary tract infections can make the lactate go very high, hepatic failure, and then high lactate is often a feature of organic acidurias, urea cycle disorders, fatty acid oxidation disorders, galactosemia, and so on. Okay, so once that is completed, then only are you going to consider the metabolic diseases that is primarily to do with lactate. And in fact, those glyconeogenesis and glycogen metabolism I've actually just discussed. So that's what we've discussed under hypoglycemia. They often have hepatomegaly, and you have to do that fasting and postprandial glucose and lactate, and that's going to give you the answer. But if you have more or less constant hyperlactatemia, then what you are going to consider, and you've excluded all of these, then you're going to consider pyruvate dehydrogenase deficiency, pyruvate carboxylase deficiency, and then mitochondrial disorders. And I think a lot of people know this, but for these, then it's normally pyruvate dehydrogenase deficiency or a pyruvate transporter defect. And if it's high, then you have to distinguish between your mitochondrial disorders and the pyruvate carboxylase deficiency disorders and those of the Krebs cycle. And the way in which we do this is we look at the ketones, but the ratio of 3-hydroxybutyric acid, which is the one group of ketones, to acetoacetic acid. Now, in the mitochondria, if the NADH cannot be utilized, then it's going to push the equilibrium between 3-hydroxybutyric acid and acetoacetic acid in the direction of 3-hydroxybutyric acid. So when we look at the organic acid profiles of these patients and we see that they've got a high 3-hydroxybutyric acid, but they've got low acetoacetic acid, then we're going to say, okay, but this ratio is increased, and that's going to make us think that there is perhaps a mitochondrial disorder. If it's normal, or if it's kind of like in balance, so we see both 3-hydroxybutyric acid and acetoacetic acid, then we would consider either pyruvate carboxylase, biotinidase, which is going to have some extra markers on the organic acid profile sometimes. Same for oligocarboxylase synthase deficiency and also alpha-ketoglutarate dehydrogenase deficiency. Now, you can actually do this as well, because the point of care ketometer that the Path Lab use measures mostly 3-hydroxybutyric acid, whereas your urinary dipstick measures mostly acetoacetic acid. So if you do those and you see the patient's got a high 3-hydroxybutyric acid, but the urinary ketones is not particularly prominent, then you would think in the line of a respiratory chain disease. Again, for many of these, there's little to no metabolic markers, and unless you've given us the clinical information in the appropriate laboratory test, there's a high probability that we'll miss one of these. Okay, then ammonia. The important thing just to remember about ammonia is that it's not just urea cycle disorders that gives very high ammonia, but some of the organic acidemias can actually give hyperammonemia to a greater extent than the urea cycle disorders, and particularly isovaleric acidemia, propionic acidemia, and then methylmalonic acidemia, and the cobalamin disorders. And these are all very common in South Africa. What is useful here is if on your blood gas, if the patient has got a respiratory alkalosis, then it is normally a urea cycle disorder. If it has a metabolic acidosis, then it can be an organic acidemia, but it can also still be a urea cycle disorder. So these are disorders that gives high to very high ammonia. And then there's a number of other metabolic conditions that gives milder ammonia levels. That is, of course, also important for us to note. Acid-base, just very quickly. If it's an acidosis, we're going to look at the anion gap. If that's high, then it means that there is an unaccounted acid within the body. One of them could be lactic acidosis, so you can measure that yourself. And again, that information is important to us. Ketoacidosis, you can also measure that yourself, or we can measure it. And then dicarboxylic acids and other organic acids is typically what we see on organic acid analysis. But so if we see a high anion gap metabolic acidosis, we want to find the organic acid that is causing that, and it is supposed to be one of those that I've listed there. And then if it's a normal anion gap, then it means that there's no aldosterone or there's no aldosterone effect, and that's usually the salt-wasting congenital adrenal hyperplasias and distal renal tubular acidosis. Alkalosis, I've already told you, if it's a respiratory alkalosis, then it's usually a urea cycle disorder. If it's metabolic alkalosis, then it can be a salt-retaining congenital adrenal hyperplasia or one of these weird and wonderful disorders like 11-beta-hydroxysteroid dehydrogenase deficiency, Barter and Gittelman, and congenital chloride diarrhea. Barter and Gittelman, I remember because it's sort of weird and pretty names. Okay. So just briefly on CK or creatine kinase, what is useful here is to distinguish between whether it's constant or episodic or fluctuating. If it's constant, we'll think of glutaric aciduria type 2, Pompe disease, mitochondrial disease, and some of the CSGs. And then when it's episodic and fluctuating, we'll think about a fatty acid oxidation disorder. Quite important in adults with fatty acid oxidation disorders. There you don't always see hypoglycemia, but you will see this fluctuating CK. And then some of the muscle glycogen storage diseases, and then AMP deaminase deficiency. But important, there are other genetic conditions that also cause increase in creatine kinase, and some of them higher than the metabolic diseases. And then there's also some non-inherited causes of an increase in CK. But nevertheless, if we do find it, it is useful and sometimes can be a key clue. Earlier this year, I think it was this year, I missed a patient with glutaric aciduria type 2, and the clue there was actually the high CK, and I missed that. Okay, then vitamin B12, folate, and homocysteine. We do this when the patient has got megaloblastic anemia, and as you very well know, I mean, we can slot in a B12 deficiency with B12 absorption and transport. So in those instances, the patient's going to have megaloblastic anemia and low B12. And similarly, if you've got a folate deficiency, you're going to have megaloblastic anemia and you're going to have a low folate. But there are disorders of vitamin B12 metabolism that one can also get clues from a megaloblastic anemia. So vitamin B12 is metabolized to both methylcobalamin and adenosylcobalamin. And it's the disorders that results in a deficiency of both or methylcobalamin that is going to give you a megaloblastic anemia. So that may be a clue for us. And all of these disorders of vitamin B12 and folate results in an inability to convert homocysteine back to methionine, so they present with mild increase in homocysteine. But very important, cystathionine beta synthase deficiency or classic homocystinuria presents with a very high homocysteine but normal B12 folate and no megaloblastic anemia. We can't measure homocysteine in the laboratory, not because we can't, but because it's not stable, but the laboratories measure this. So again, if you don't do this and you don't share the result with us, it's very likely that we could miss a classic homocystinuria. We may spot it because of the high methionine, but there's also a reasonable chance that we can miss it. Methionine is fairly non-specific. It's always increased with liver disease and so on. So it's important that we have these results. Then in the interest of time, I'm going to skip these, but there are reasons why we would do the other tests, not as strong as what I've just shown you, but they may be important under some circumstances. Then, if there is a new metabolic screen for 2026, then really what it should be is organic acids and then serum amino acids and serum acylcarnitines. And there is a wide range of clinical ways in which a patient can present where these tests will be appropriate. So if you really don't know what to request, this is what you should do: urine organic acids and serum amino acids and serum acylcarnitines. And that's going to cover a lot of things, but it doesn't cover everything. And that's why I think the request tool is quite important. I'm also not going to go into detail with this, but these are just all the clinical features that I've considered in constructing the selection tool. And some of them are quite diverse. So if you take, for example, the 6-plex LSD, it includes conditions like Gaucher, but then also Fabry and also Krabbe and so on. So you will see that it's quite diverse. So there are many instances in which you would end up doing a 6-plex LSD. Fortunately, this is a free test, so you don't have to worry too much about that. But for each of these, there are specific symptoms that we use in the back end of the tool to ensure that it flags the test if a particular clinical category was selected. And this is applicable to all of these. There are 2 tests included here, MPV-17 and white blood cell cysteine. MPV-17 is for a mitochondrial depletion syndrome, and white blood cell cysteine is for cystinosis. These tests are offered by the NHLS, not by us, but the path labs will send it there directly. Again, it's useful for us just to know that you have requested that, and we can contact them and ask them if they've managed to make a diagnosis with the test. Okay, I'm almost done. I see we're out of time. So the test selection tool is a fairly quick way, if you've got a particular category, that you can put your patient in to get to an appropriate number of tests. But it will result in some test, over selection or over testing, if I can put it like that. Not too much, but there is some degree of that, just because, if you delve more into the clinical presentation of the patient, you're going to be able to eliminate perhaps some of those tests. Like the example that I showed with dysmorphology. You select dysmorphology, but dysmorphology is an umbrella term for a number of presentations. And if you could be more specific about the presentation, then one can be more specific about the test that you should organize or order. So for that reason, there exist these online tools that is becoming, to my mind, more and more useful. I think you do need some background knowledge to use them, but they are very useful. I've shown IEMbase on a number of occasions, so I'm not going to show that again. I regard this as particularly useful, and also when you have the results. So if we tell you that orotic acid is high, you can go into IEMbase and you can slot in your clinical, you can slot in orotic acid, and it's going to give you a differential. And maybe if something pops up that that is of relevance, that you see, okay, no, but my patient actually has this as well, and I'm able to make the diagnosis. The problem with IEM base, it's only metabolic diseases. And of course, the patient don't present with a metabolic disease, they present with a disease. So there's a large number of diseases that's not covered by IEM base. But I must say, I think there's something like 1,500 diseases in it, which is, I think, well, Rare MD has got more. Rare MD, I think, has got almost 5,000 diseases in it. AccelRare has got less in it. But it's not completely comprehensive from a clinical perspective. Rare MDX and AccelRare is definitely more comprehensive. And for tonight's presentation, I'm just going to show you a short video on AccelRare. I haven't used it myself that much, but I do intend to use it more. But I think this tool is for complex patients, So if you've done a few things and you still don't have an answer, because you'll see it takes quite a while to actually complete the request. But I do think we will find it very useful with our complex patients. And the other thing is, of course, you'll see at the end, you can print it. And of course, that printout you can also send to us so that we know in which line you're thinking. Okay, so here goes the video.
Chris, I don't think you should mute yourself because we can't hear the video.
Oh, okay. Why is it now not playing? There we go.
AccelRare is a pre-diagnosis digital tool made available to healthcare professionals free of charge on internet in 2 languages, English and French. AccelRare can suspect 270 rare diseases called loss of chance, for which an adapted care exists today. To start the pre-diagnosis, every doctor just has to select his practicing country and certify that he is a healthcare professional. The HCP is first invited to enter the age and the gender of his patient. It allows to filter all the possible diagnosis hypotheses to this population. The physician should then describe the complete clinical board of his patient, all his symptoms, all his personal or family medical history, and all his medical exams. It allows Medver algorithm to scan the 270 rare diseases managed in comparison to this clinical board and to determine the first set of diagnosis hypotheses. To refine it, Medver identifies the main differentiating signs of each of these suspicions and questions the physician. This one should then specify those which are also applicable for his patient. The hypotheses are automatically recalculated. AccelRare presents the final diagnosis hypotheses. Our commitment is that the right disease is among the top 5 suspicions. For each disease suspected, AccelRare assists the practitioner in his decision-making by providing 3 key elements. The physician can consult the complete description of each suspected rare disease so that he can better reappropriate it. He can find notably all the evocative signs and all the combinations of signs which should evocate this disease. He can also consult the list of best complementary medical exams he could prescribe in a liberal environment in order to reinforce the level of suspicion of the disease. These exams are ordered from the most discriminating to the least discriminating.
Okay, right. So yeah, just my own view on the tool is it's a bit slower to complete it than what you've just seen in the video. But I think if you've got that very troublesome patient, you do take the time to do this accurately, you probably are going to end up with your diagnosis within the first 5 on the differential like they proposed they are going to do. But time will tell, but I'm actually very optimistic about this tool, and I think it's going to help us a lot. So that concludes my talk, and I'm happy to take questions.
Thank you, Chris. So there's already one question in the Q&A. Just again, I invite you to raise your hand if you wanted to ask the question live, or type in the chat box or Q&A. Okay, so there's one question in Q&A from Prof. Chris Hendricks. Does the tool give information on the best association with food to collect samples? For example, serum amino acids are more reliable when fasted and early morning due to diurnal variation. Of course, some conditions you don't want to fast, like FAOD, or be pragmatic and just collect them when possible at start of diagnostic journey.
Yeah, Chris is right. I mean, collecting samples in the correct state is very important. Just before I check that we've actually included that, otherwise that will be the first thing that we'd have to do. Yes, I mean, it's sometimes difficult to advise on fasting because fasting is a method that could get the patient into trouble, for example, with a fatty acid oxidation disorder or glycogen storage disease. So what we normally recommend is that the parents or the patient just follow their normal routine and collect the first morning sample. So if the parents say, okay, well, we feed our baby every 4 hours, then we would say, okay, you know, what is the closest feed to 8 o'clock? And if they then say, okay, well, we feed it at 8 o'clock, then we see, okay, well, then let's collect the sample just before that first morning feed, because normally that last stretch before the first morning feed is normally the longest stretch. So we don't want to go for longer than what they're already doing themselves, and that's usually the way in which we approach it. Now, I think the tool does actually include that, but I'm going to be a little bit embarrassed if it doesn't. See?
It doesn't.
I thought it was actually here with the collection. Okay, but that's something that we then just going to have to sort out. I thought that it would be here on the collection. Of course, if you go into our diagnostic services, there you will find information on whether it should be collected in a fasted state or not. But I think we can fairly easily bring in fasted or not. I can't remember exactly, but the idea may also have been that, you know, if we don't specify, then we actually want it to be in a fasted state. Normally, we want tests in a fasted state. The only time really when I recommend it in a non-fasted state is when I want to know postprandial glucose and lactate. I can't really think of another example where I collect in a postprandial state. But yeah, so usually it is fasted.
Okay, there's no other questions yet, but I just wanted to mention, or I wanted to comment and say that, yeah, Chris, thank you. I know that this took a lot of effort and a lot of work and a lot of days to set this up. This is the very first version of the tool, and we will be happy to welcome any suggestions or any feedback from anyone in the audience or anyone else. If you wanted to give us some feedback on what we can change. Chris, then I just wanted to ask a more practical question on the print and email part. So if you are the clinician requesting this, instead of printing, can you also request that it's emailed to you if you want it?
Yeah, you actually don't
automatically
print it. So
email?
You can see my screen, right?
Yes.
Yeah, so you actually don't print it. So when you press submit, it's going to send it to this email that you have selected here at the top. But then I think practically speaking, you'd probably want to print it so that the patient can also sign it. On the other hand, let's say if you were on ward round and it was done on a tablet and the patient signed on the tablet, then you can probably just email it. So, but that's something that we have to discuss with the path labs, if there's an email address to which they can email this. And then, you know, that can basically be an instruction for collection. Yeah, so that's certainly something that we can consider. We've looked at this from a perspective of, you know, how we think people would likely be able to utilize it best. But it may be that we're incorrect, and then, you know, please contact us and make suggestions on how we can change it. We want this to be usable. I know that, you know, ward rounds can be extremely busy, and practice can also be extremely busy, and this is also why we try to keep this as simple as possible. You know, really just go and select that one category that your patient fits in. So we try and make it as quickly as possible, but in order to do this properly, we do need some information from your side. So there's lots of requests to the metabolic laboratory with no clinical information whatsoever, and you know, of course, we do our best with every sample, but we can often provide a better service if we just have really just key clinical information. We don't need everything, but we need that key presentations and key aspects from the history and so on.
So there's a comment in the chat from Sibongile Mbata saying, thank you for an informative and important talk. Looking forward to interacting with the tool. Hopefully we can get an app form of the tool as well. So we don't have an app yet, but what we do have is a WhatsApp channel that's already in use. And I think we should add this link to the WhatsApp. So I know it's difficult if you're on your phone or on a tablet to go to a website and then look for whatever it is. So Chris, maybe is that on the website live? You can just show at the bottom, there's a WhatsApp number.
Yeah.
Yeah. Contact
home
us.
screen.
For home, yeah, the bottom. So there's a WhatsApp number at the contact us on the left.
Yeah.
Yeah, left.
I'm going left.
Contact
More
us.
left.
Yes.
Oh.
That contact us, yeah.
Oh. Contact us. Oh, okay, there. Okay, thanks.
So there's a WhatsApp number there.
Yeah.
So if you go to that WhatsApp number, that's a bot. It's a robot that can give you automatic answers to some of your frequently asked questions. And I think what we will do in response to your question there is that we will put a link to this form, a direct link to the form on the WhatsApp. So if you're on your phone or a tablet, it's then easy to go to the WhatsApp, click on the link instead of going through but we will think about the app in future, definitely.
Just also, if you just put the URL on your phone as a link, the website, the phone version of the website works quite well. So when you go to this text selection tool on your phone, what's going to happen is you're not going to have this legend next to the pathology test. You're going to have it at the bottom. But it works quite well. You can go through it. You can enter your email. You can submit it. And you're still going to get it to an email that you can access from a computer somewhere and print the form and so on. So even without the app, it already actually works quite well. But yes, I agree. An app would be nice.
Okay, so there's another comment from Mariana Lloyd saying that, will you include a consent option for the patient to approve that his or her general lab results can be sent to the NMP? So you mentioned that you add yourself as a copy doctor, but is this only for this test on this form, or does it also include tests that's been done previously for this patient?
Okay, look, I mean, it would work like any laboratory form. Whoever is the doctor and the copy doctor on the form will receive copies of the result. But if we want to get other information about the patient, this is not just laboratory information, it may also be radiology, then just having this form doesn't automatically allow us to do that. So, and that's why we have this additional tick box that they have to tick, where they give us consent to actually request additional information. So it's requesting additional testing, information, and reports required for diagnostic purposes. So if they tick that, then I think, but we can discuss it if something more is needed, but I think this is enough evidence that the patient has given consent for us to access previous information, be that laboratory information, radiology, even summaries from previous clinicians and so on. And then, I didn't go through this yet at the bottom, but this is also for purposes of the patient, where we explain who we are and what we do, and that we need this information for diagnostic purposes, and that's the only reason why we require it.
So the second consent there is consent to contact. So this gives the lab consent to directly contact the patient. Is that correct?
Yeah, but like I said in my presentation, when we do that, we never exclude the clinician. So we may contact the patient, enroll them in the Nngwe program and so on, but the referring clinician remains the initial clinician of the patient. And we will liaise with the clinician if there's any findings on the patient and so on. So because I know a lot of clinicians, they want to be kept in the loop when additional things are done in the patient, and we constantly keep clinicians in the loop, even though we have consent to contact the patient directly. This is just because clinicians are extremely busy people, and to be quite honest, if you have to rely on them to get permission to contact the patient, then it doesn't always work out. So this is a better way of doing it, but don't worry, we keep you in the loop.
And then just another practical thing. So for clinicians who've been using our labs for years and years now, there's a different consent form and a different patient information form. So does this form substitute the old form that they used to fill out with all the clinical information?
Yeah. So the old form, I mean, the problem with the old form is that it actually requests too much information and it doesn't rank that information. Yeah. So there were lots of tick boxes there that you had to tick. And then when we get the information, it's just a list of clinical features. So what we really want is that presenting clinical features that was key at the presentation, and then key features from the history. 5 words, 5 well-considered words that's key to the patients, often more important than, paragraphs of writing of what's happening to the patient now, who has now progressed to liver failure and kidney failure and, lots of things that is not necessarily of relevance to the initial presentation.
Okay, and then just last, I'm just asking questions that I think some of the clinicians would be wondering about. So in the past, you would fill in the form that we had and send it to the lab. Some people would have sent it to us via email or so on. So if you submit this, you physically give this form to the patient takes it to the path lab, and it will be sent to our lab via the path lab. Is that correct? Or is it sent to us in any other way?
No, you're absolutely right. So it gets sent to us by the path lab. Either you've got the patient in your consultation room, you fill this out, you give it to the patient to take to the path lab along with your laboratory request form that has your mnemonic on it, or you put it in the patient's file if the patient's in hospital, and so that if the phlebotomists come along, they can then collect the correct test. Now, on the back end, we still do also receive a copy of the form that you've completed automatically. So whenever you press submit, and a unique number is generated for this form, and that gets sent to us. But of course, that may not actually have the completed patient section in that. So we may not be able to contact the patient. And of course, the other thing that happens is that people may actually use this tool just to see what test should be selected without actually sending off the test. So the forms that we receive, we're not going to monitor them to see what is supposed to come in. That's just going to be a mammoth task, and I think we're going to bug people and they're going to become very angry. But for record purposes, and also just to see how people are interacting with the form and how they are using it, we will receive copies of the form. But you need to send this form with the laboratory test request form and the samples to our laboratory. And then when we receive it, we will then use the clinical information that you've given us, and we will automatically receive the pathology test that you have selected. That will come automatically to us.
Yes. So that's the form will physically come to the lab, and there's no need for you as a referring clinician to then also email this to us. You don't have to download it.
No need to do that.
Us, please don't do that. Okay. There's no other questions or further questions, but I really encourage you, if you have any questions or suggestions, please send us an email, or you can go to the same website where you will find this and go to the contact form and send a message then directly through the website via the contact form, or if you have our direct details, please send it to us. Again, we really welcome any suggestions or input from your side. Okay, we went a bit over time, but it wasn't the whole evening. So thank you very much, Chris. Thank you again for the time that you took to develop this tool, to set it up on the website and to present it. We really appreciate it. And I think this would really make everybody's life a bit easier.
Thanks, Ilse, and thank you to everyone who attended. I look forward to a new era of metabolic testing and more diagnoses, starting now, but especially in 2026 going forward.
And then lastly, just again, thank you to Sanofi again for sponsoring this. We appreciate your support, and thank you for everyone who joined. We had a big crowd this evening, and we really appreciate you taking your time on a Wednesday afternoon to join, or evening to join. Zai, thank you very much for your evening. Bye.
Thank you. Bye.